Hello and welcome to the Laboratory Matters, where we discuss all that matters in the laboratory. I'm Dr. Rani Radhakrishnan, and today we're going to discuss about the second module of our series, which is titled All Red Cells Are Not Discs. In the previous module, we saw about the definition of a poikilocyte, why poikilocytes are created, and we also discussed about the spiculated cells. Today, I'm going to talk about another group of poikilocytes which comprise elliptocytes, ovalocytes, stomatocytes, teardrop cells, and target cells. So what are elliptocytes? Elliptocytes are something that we see very commonly, and everyone who's reporting smears in a hematology laboratory is going to see elliptocytes almost on a daily basis. When do you call a red cell an elliptocyte? A cell with a long axis more than twice its short axis should be designated an elliptocyte. That is, it is longer than it is broad. So more than twice the short axis. And where do we see it? Most commonly iron deficiency anemia, at least in the Indian context. You also see it in a condition called hereditary elliptocytosis, Southeast Asian ovalocytosis, where elliptocytes are associated with ovalocytes, macroovalocytes, and stomatocytes. Now, very important to note that we need to distinguish a true poikilocyte from a smearing artifact, especially in the case of these elliptocytes. So, pseudo-elliptocytes are a result of a smearing artifact. And how do you differentiate between a true elliptocyte and a pseudo-elliptocyte? A pseudo-elliptocyte will all be pointing in the same direction, that is in the direction of the spreader. Whereas true elliptocytes will be in all directions. This is something that you need to keep in your mind all the time when you're reviewing smears. So like you see elliptocytes here, they're in all directions, they're intermixed with cells. Here, these are the elliptocytes which you can see where they are over here, over here, over here. Maybe the arrow is a little misplaced. So these are all elliptocytes, and these elliptocytes are longer than they are broad. Now, a little bit about hereditary elliptocytosis, because this is a condition which, unless you know about, you will not be diagnosing it. So you should not confuse it with iron deficiency anemia. So HE is a membrane disorder, and it is due to the defect in either the structure or the quantity of the cytoskeletal proteins which make up the membrane of the red cell. So when a particular protein that forms the cytoskeleton of the RBC is either less in number or it is defective, then it will not be able to form the biconcave structure of the RBC. So the most common abnormalities are mutations in either alpha or beta spectrum. Now, why does it become this elliptical site? Because due to this membranous defect, that recoil of the RBC is not there. So when an RBC is traversing through the through the blood vessels, sometimes they have to change their shape as they navigate. And because of the elastic recoil that is present in the membrane, they bounce back to their discoid shape. Now, because this is lacking due to the defective cytoskeletal proteins, these will lose their discoid shape and it will assume a fixed characteristic morphology of the elliptocyte, which has a decreased surface to volume ratio. Also important, because these become fixed, they become less deformable, and because they are less deformable as compared to a normal red cell, they are trapped and removed by the spleen. So it is like a defective cell. So therefore it is not deformable, and there, or rather less deformable than a normal RBC, and gets trapped by the spleen and it is removed. How do you diagnose HE? Now, this is usually picked up in the laboratory, MHC patients, or patient coming for something else, you just look at the smear and you will find plenty of elliptocytes. Now, rarely these HE patients can present with hemolysis, when you will definitely have a look at the smear and reach a diagnosis. The most important thing here is that at least 25% of the cells, the red cells, should be elliptocytes to classify it as HE. Usually in HE, you will have more than 50% of cells which are elliptocytes. Now, the question is, even in iron deficiency anemia, you can have elliptocytes. But if you notice, in iron deficiency anemia, the elliptocytes are also hypochromic and they are associated with red cells which are microcytic and hypochromic. So you cannot, or you very rarely confuse the two. Now, HE can also have variants. Important among them are hereditary pyropoikilocytosis, which has an increased number of microspherocytes. Stomatocytic elliptocytosis, which has spherocytes and elliptocytes, and you also have distinct RBCs, which are rounded elliptocytes bisected by a bar of hemoglobin. Then Southeast Asian ovalocytosis, where you have characteristic morphology with one or two transverse slits across the body of an oval-shaped RBC. We're not going to see them every day, but it's good to remember so that in the event you see it, you're able to recognize them. Now, yes, I've seen elliptocytes, they're more than 25%, but the International Council for Standardization in Hematology has guideline recommendations. How will you diagnose this HE? So you have to do a sodium dotacyl sulfate polyacromide gel electrophoresis, STS page electrophoresis, where you will quantify protein 4.1 spectrin analysis. So here the spectrin dimer content, spectrin variants, ankyrin, all this you will quantify, and if it is low, then you will say, okay, there is a defect and this is most likely to be HE. You can also do another test which is called osmotic gradient ectocytometry, where you get a deformability index. Now this shows maximum deformability, which is characterized by a trapezoidal curve in patients with HE. Honestly, this is all theory for me, and since these are the recommendations, they have been put here so that we are all aware of the recommendations. Or unless you have a very dedicated laboratory, these things are not going to be done except in probably a center of excellence or a reference laboratory. But this is how you diagnose, where you're proving that there is a defect in the cytoskeleton and also that there is a decreased deformability index vis-a-vis a normal red blood cell. Then we go on to ovalocytes. Now, very little to distinguish between an ovalocyte and a elliptocyte. Okay, it's just in how the shape is. So, an elliptocyte is elliptical and an ovalocyte is oval. There's very little difference again between the two. So, we all just heard that an elliptocyte is the long axis is more than twice the short axis. Here it is less than twice the short axis, and that is called an ovalocyte. So these kind of cells which are like more oval than round are called ovalocytes. Greater than 25% ovalocytes or oval cells will be called hereditary ovalocytosis. Again, this is also because of a defect in the cytoskeleton, which is a mutation in band 3, and other proteins may also be involved. So that is spectrin ankyrin, and here it is more band 3. So these shape changes are more because of different cytoskeletons that are defective either in quantity or in their functionality. Now, we usually take them together, and these are seen in smaller numbers in heterozygous and homozygous beta thalassemia, megaloblastic anemia, primary myelofibrosis, and myelodysplastic syndromes. Occasionally, you're seeing it in inherited red cell enzyme abnormalities like pyruvate kinase deficiency. Now, a point of interest, a point to note is whether it is HE or whether it is HO, that is elliptocytosis or valocytosis. It is only the mature red cell that is a poikilocyte. The reticulocyte is round in contour. Very important to remember. So that means only in the last stage of maturation does the cell assume an abnormal contour despite it being a genetic defect. So although the causative condition is inherited, the abnormalities become apparent only as the cell reaches maturity. So in hemolysis, when you're having a HE with hemolysis, you're going to be seeing more of cells, the reticulocytes, which are round in contour. An interesting thought. So these deformities only occur in the late stage of maturation. Again, another pointer that you must keep in your mind. Now we'll move on to stomatocytes. Stoma is mouth. So in dried films, the central biconcave area, instead of appearing round, will appear like a slit or like a mouth. This again could be an artifact. Again, all these poikilocytes can be smearing artifacts, drying artifacts, and so on. In wet films, it appears as a cup-shaped wet cell. Now, where do you see stomatocytes? Hereditary stomatocytosis, Southeast Asian ovalocytosis, and in acquired conditions like liver disease, alcoholism, and MDS. In vitro artifact due to a decreased pH or an exposure to a detergent. Now, hereditary stomatocytosis is an autosomal condition, autosomal dominant condition, which shows a defect in the membrane cation permeability. And that alters cellular hydration, causing numerous effects, including hemolysis. So we all know that the RBC membrane is semi-permeable and there is a movement of the anions and cations across the cell membrane. So there is a defect in this permeability, because of which the cell can either become overhydrated, when it's called overhydrated hereditary stomatocytosis, or hydrocytosis, where the cell will become swollen, or it can be dehydrated hereditary stomatocytosis or xerocytosis. It can also be cryohydrocytosis, when it is the temperature related, and familial pseudohyperkalemia. So these are all conditions where on the peripheral smear, you're going to see stomatocytes. And like I said, these cells which have little mouth-like slits, little smiley kind of cells, are diagnostic of stomatocytosis. So now in overhydrated stomatocytosis, obviously the MCV will be high. There's macrocytosis and the MCV is almost 110 to 115 femtometer, but the MCHC is decreased. Obviously there's less of hemoglobinization because of overhydration. In dehydrated stomatocytosis, there is still macrocytosis because these cells are slightly macrocytic, but the MCHC is elevated, and that is how you differentiate between the two. So it's important that when you diagnose stomatocytosis, that you see plenty of such cells and they are not artifactual. Next, moving on to dacryocyte. Dacryocyte is a teardrop cell. Okay, it has a blunted tip and it points in different directions. Okay, so it's not that you have one cell all these cells in the same direction. So all these are dacrocytes. All these are dacrocytes, and you can see that it is like a teardrop. That's what it, or a pear shape, whichever you want to call it. Again, it can be a smearing artifact, but it will all be in the same direction as the spread. Where do you see dacryocytes? Myelofibrosis, primary or secondary. It's quite a classical feature in myelofibrosis and to an extent diagnostic also. Megaloblastic, or at least you should start thinking about myelofibrosis. So that is one of the pointer cells. Megaloblastic anemias, thalassemia major, hemolytic anemia. In many conditions, the number of dacryocytes decreases after splenectomy. Means it all is getting changed again at the end. Now, what does this suggest? That cells are formed during extramedullary hematopoiesis and not in the bone marrow. Abnormal red cells are further damaged during the passage through the spleen. So, this is again important. If the patient, if you have seen, if it's a myelofibrotic patient and he has had a splenectomy, the number of dacryocytes will decrease when you're examining his spear. So the presence of these teardrop cells, say you're looking again at an MHC patient, elderly or an elderly male, and you're seeing counts which are slightly on the lower side, and you're seeing these teardrop cells. Look for evidence of dysplasia, and probably you're looking at a case of either myelofibrosis or you're looking at some other kind of a red cell disorder. I'm sorry, hematopoietic disorder. So the presence of dacryocytes is also significant, and one should look for the cell. So when you're examining the smear, don't give it a cursory look and keep looking for the red cells. It's always what we do. We only are looking at the white cells, and then if there's thrombocytopenia, we're looking for platelets. But we tend to ignore the red cells, which actually form the major portion of the smear. So you will be able to get lots of small pointers which will help you in the diagnosis, which will help you tell your clinician to look further and lead up to a diagnosis. Then we move on to target cells. Target cells are again very nice looking cells. Some of the poikilocytes which will hit you straight on your eye when you're looking at a well-stained Romanowski smear where the buffer pH is maintained. So these are erythrocytes with an increased cell membrane to volume ratio. Okay. So in an elliptocyte it's decreased, in a target cell it's increased. Now why is this cell membrane to volume ratio? Why is it altered or why is it increased? Because there is a gain of membrane lipids or the cell volume gets decreased. Usually it is the cell membrane which gains lipids, and therefore the cell membrane increases in bulk compared to the volume. The cell surface is disproportionately large compared to the volume. Why is it called a target cell? Because it looks exactly like the target, the bullseye. Okay. It results from clustering of intensely staining hemoglobin around the periphery. Then there is a non-pale staining area, and again there is a dark staining area in the center, similar to how a target or a bullseye looks. Now it is also called podocyte, which is because it has a bell-like appearance on electron microscopy. Now these target cells can be normocytic, can be microcytic, and can be macrocytic. Okay. Now macrocytic target cells are seen in liver disease, in which the cell membranes are loaded with cholesterol. It's also seen in dyslipidemias, hereditary hypobeta-lipoproteinemias. So when you see a target cell on the smear, first see the size. Okay. And if it's macrocytic, you look for other evidence of liver failure or liver disease, which could be echinocytes, which could be spur cells, which could be acanthocytes. So you will look for such things. You look for macrocytic cells also. A normocytic or a microcytic target cell is seen in thalassemia, hemoglobinopathies like hemoglobin E beta thalassemia, hemoglobin C, E, hemoglobin H disease, post-splenectomy, sickle cell disease, iron deficiency anemia, and artifact during smearing and rapid drying. Here target cells are again irregularly distributed on the smear. So you should never, unless you see here and there some target cells which are not well defined, those are the artifacts. But when you see nicely formed target cells, you first go and look at the size. And when they are large, it's more likely to be non, non, uh, non-red cell related. Okay, and it is probably due to liver disease. When it's normocytic or microcytic, then it's because of red cell disease, thalassemias, hemoglobinopathies, post-splenectomy, or sickle cell anemia, iron deficiency anemia. All this can give rise to target cells. Let me show you. Now, these are large target cells or macrocytic target cells. See the macrocytes. You can see scattered macrocytes, and you find lots of target cells. I've also included an acanthocyte for your benefit and an echinocyte for your benefit. So this is liver disease. Okay. Whereas compare the two targets. This is nice. This is normocytic. You have a few which are microcytic also, and these are because of hemoglobin E disorder. So when it is hematological, red cell related, you'll have normocytic and microcytic targets because you can see microcytic cells, you can see some spherocyte, whereas this is due to liver disease. So when you look at the smear, you have to look at the shape, you have to look at the size, you have to look at the distribution, you have to look whether they are in the same direction, whether they are multidirectional. All these things one needs to keep in the mind. And I keep saying this whenever I talk to people, that for everything that we see, as we continue on our journey, as we continue our learning processes, you need to have check boxes which you need to tick off. And if we have check boxes for every condition, then it's very, very easy. You can't obviously keep it next to you. It has to be more a mental checkbox. What am I looking for? Target cell. Is it a target cell? Is it a real target cell, or is it artifact? Is it big? Is it small? Is it macrocytic? Is microcytic? Normocytic? Any other cells along with it? Then you come to white cells. Then you look at the platelets. So when you have a pattern, a method in every madness, it's easy to diagnose. So we've done these 4 different poikilocytes, and just to sum up, elliptocytes are cells where the long axis is more than twice the short axis, seen in iron deficiency anemia, hereditary elliptocytosis, Southeast Asian ovalocytosis. Ovalocytes are cells where the long axis is less than twice the short axis. It's seen in hereditary ovalocytosis. Stomatocytes are seen in hereditary stomatocytosis, Southeast Asian ovalocytosis, acquired conditions like liver disease, alcoholism, MDS, and as an in vitro artifact. Dacryocytes or tear cells are seen in myelofibrosis, primary or secondary, megaloblastic anemia, thalassemia major, and hemolytic anemias. So you have to understand that you can see these cells not just in hematological conditions, but also in systemic disorders. Target cells have an increased cell membrane to volume ratio. They could be normocytic, microcytic, or they could be macrocytic. Macrocytic seen in liver disease, and normocytic or microcytic seen with all other red cell diseases like thalassemias, hemoglobinopathies, sickle cell disease, and iron deficiency. So I hope that this has given you an insight to look deeper, look for the different cells and identify them, and then, understand from where they're coming, the etiopathogenesis, and so. I hope you've had a good time listening to me. We're not done yet. We still have a couple more poikilocytes to go. So continue watching and wait for module 3 of All Red Cells Are Not Discs. And if you want some more content, if you want to look at more videos, if you want to look at more courses which will teach you different things in laboratory medicine, I request you to visit our website, thelaboratorymatters.com, where there are numerous courses. Depending upon your likes, you can choose them and learn and continue with your learning process. I want you to like, comment, share, and subscribe to this channel so that we can continue on our long journey of discovering all those things that matter in the laboratory matters. Happy learning with the laboratory matters. Thank you.